Now, why is rheumatic fever important? Because it is the commonest cause of acquired heart disease. Right? So if you go to Western countries, the commonest cause of acquired heart disease is, if you go to Japan or US, it's Kawasaki disease. But in India, as of now, the commonest cause of acquired heart disease is rheumatic fever. Right? So again, we have a huge chunk of diseases, heart diseases, which are congenital. So usually we have VSD, ASD, TOF, which is congenital, and this is the bulk of heart disease, which is because of rheumatic, that is acquired, that is because of streptococcal infection. So actually you're supposed to know, we are going to study about why it occurs, how it occurs, right? What are the clinical features, and if it can be prevented. Now, why is it that rheumatic fever is common in our countries? It was like this in the US a few decades back. It's not there anymore. So how have they been able to prevent it, right? So basically it's the improvement in hygiene, the improvement in, they don't have overcrowding, improvement in the socioeconomic status. So you find that it can be prevented. So basically it is, what is happening is, that it follows would be streptococcal infection in the throat. So is it the infection which is causing rheumatic heart disease? No, it's not the infection. It's the immune response that occurs. So it's kind of, you can say, immunological phenomena. So what the body does is, you have a streptococcal infection, then you have a lag or a latent period, right, during which the infection subsides, but the body boosts the immune response. And those antibodies, the antibodies which are generated against the streptococcal cell wall antigen or the polysaccharide, they confuse your body. There's a kind of mimicry, and they confuse certain antigens which are present in the heart valves or in your joints or in your brain, and these antibodies then cause an immunological phenomena which causes rheumatic heart disease, right? So what we've seen is that the features, like the involvement of other parts of the body. Usually the children have high-grade fever, they have joint pains. We have a classical, you studied about Jones criteria, you must have studied in pathology also and medicine also, I think. So you have these features which involve other parts of the body, but what you find is that the body recovers completely from these features. If a child has joint pains, the child will recover completely. There will be no residual sequelae in the joints. If he has chorea, he will recover completely. There is no neurological phenomena. If the child has got skin lesions like erythema marginatum or subcutaneous nodules, everything will recover completely except for the heart valves. So it is, and the heart involvement is also a kind of pancarditis. It involves all the three layers. It involves the pericardium, myocardium and endocardium. So what we see is that the peri and myocardial involvement will also recover. The joint involvement will also recover. It's only the endocardial involvement which causes problem. And that persists. And that is a very important cause of morbidity and mortality in children. I mean, they become adults, so the manifestations occur in adults. Right? So what we are worried about is the involvement of the valves, right? So basically it's basically related to an infection, but is it the infection? So if you just treat, so the main treatment of rheumatic fever is not anti-streptococcal antibodies as such. Even though we know that it has an infectious origin, but we know that at the time of the infection, and if you look at the throat swab or the culture, if you look at any child who has active rheumatologic or a streptococcal infection, you will find they don't have that. So it's not the infection, it's the immunological phenomena, but what it tells you is that it can probably be prevented. There can be primary and secondary prophylaxis. If you treat the streptococcal infection, probably you can prevent it. So it gives you a hope of prevention. But again, it's the immunological phenomena caused by group A beta hemolytic streptococcus. How do we know it? Because we found that all the children who have, we find that there's a history. At least more than 50% will have a history of sore throat, usually 1 to 2 weeks back. But why everybody doesn't have a history? Some of the infections are subclinical, right? So that is why prevention is not 100% accurate. You cannot prevent every infection because you will have subclinical virus group B streptococcal infection also, which is causing rheumatologic heart disease, right? Then again, we find that whenever we test, how do we know that the child had infection in the past? We can test antibody levels. So which is the antibody we test? So usually we go in for ASO titers. So we find that the ASO titers are elevated in more than 75%. So most of the patients will have elevated ASO titers, and those who don't have ASO titers, if we do anti-DNase B titer, that is usually elevated. So you have evidence of streptococcal infection. And again, when there's an epidemic of streptococcal infection, the incidence of rheumatic heart disease increases. And wherever there is, for example, in a family you find there's a cluster of patients, overcrowding, then the incidence of rheumatic heart disease increases. And in Western countries, they don't have overcrowding, the socioeconomic condition is good, the incidence of rheumatic heart disease has markedly decreased. There will be many doctors in US who have never seen a child with rheumatologic heart disease. And in fact, if you are actually attending your clinics properly, so in your PG, whenever you're going, even as your undergraduate, like this year itself, we have had 3 or 4 patients. So if you have actually attended clinics nicely, or you're going and seeing your patients nicely, you will have at least during your undergraduate days also, you will come across a lot of patients who have suffered from rheumatic fever. Now, why do some people have rheumatic heart disease and others don't? So again, there is a genetic susceptibility also. There is no clear-cut diagnosis, there is no clear-cut HLA, this patient has this HLA type or this gene and this is why it occurs. We don't have a clear-cut etiology, but we find that a lot of children have streptococcal sore throat, but everybody doesn't have a heart disease. So it is probably some degree of some genetic susceptibility also which plays a role. So again, you find that there are certain polymorphism of interferon gamma, angiotensin converting enzyme defects or toll-like receptors. So there are certain polymorphisms, some genetic susceptibility because of these genes has also been speculated. It's not very clear-cut. So one of the things that you have to study is etiopathogenesis. So what you find is, so this is the streptococcus. It's got these M proteins on the surface. It's caused pharyngitis. And it causes formation of, it stimulates the CD4 cells and causes formation of these interleukin-2 and TNF, tumor necrosis factor alpha, stimulates the B cells to form antibodies and the CD4 cells also get stimulated. Then these immune cells, they circulate and the cytokines are released, right? Now after this, these antibodies attach to the valves and it is said that these initial damage to the valve is because of the antibodies. And when the antibodies react with the valve, they cause this VCAM1 receptor, that is vascular cell adhesion molecules to be expressed on the surface of the endothelial cells. And ultimately, there is neovascularization and later on recruitment of the T cells. Then these T cells start reacting with other cells of the myocardium also, like alpha helical proteins and so you have other manifestations also, right? So basically, initial damage is because of the antibodies. It causes expression of VCAM1 and later on you find that the CD4 cells also, they secrete a lot of interleukins and TNF alpha and interferon gamma, and this entire immune cascade damages the valves. Why we are worried about the valves, I told you, is because all the other manifestations will disappear. It's the valvular damage which persists and causes the morbidity. That is why we are worried about the endocardial damage. So again, during the incidence is 0.3 to 1 to 3%. The main age group affected is 5 to 15 years. Very rare to find children less than 3 years. So if you have a child who comes to you with less than 3 to 5 years, why? Because they are not going to school, they are not exposed to a lot of infections. This is the age group when children are going to school or Anganwadi, right, or playgroup. So they get exposed to other children who have streptococcal infection. And why we are not beyond 15? Because by that time we expect that repeated infections have given you some degree of immunity. So that is why it is not seen in very young and very old individuals. This is the age group which is affected. Incidence does not have a specific gender predilection, but mitral valve is more involved, mitral and chorea is more in females, and aortic involvement is slightly more amongst the males. Again, it is wherever you find airborne infections, overcrowding, poor socioeconomic status, people are not using handkerchief hygiene, etc., you will find the incidence is higher. So the classical manifestation is the child has a sore throat, there's a lag period, right? Then you have skin sores. Skin sores are erythema marginatum. So this is something that occurs early on, right? So fever occurs early. Then you have this erythema marginatum. Erythema marginatum are skin lesions. They occur usually in the trunk. So we are a dark race, which is not very commonly seen, right? So it's a serpiginous margin, slightly raised. The margins are slightly pale, and then you find the center is slightly raised. Then they disappear. 3 to 6 weeks, you may find subcutaneous nodules also. So subcutaneous nodules can vary from small pinhead to the size of almond. They are mostly seen over the elbow or shin of the tibia or over the occiput. And then you start having joint pains also. So again, joint pains is seen, like if you take Western literature, it's seen in 75%. Here also we find that history of polyarthritis, polyarthalgia may be present. Some patients may come to you a little late. Some people will go to different doctors. And if they are given anti-inflammatory, joint pain subsides very fast. So it may or may not be present at the time of manifestation, but history of joint pain is present, right? Then you have cardiac involvement. And chorea comes very late. So many times what happens is, by the time a child comes to you with chorea, everything else has disappeared. Usually all the things will not be present at one point of time. So you may get history of certain things. Well, you may not find erythema marginatum, joint pains, everything to be present at a single go. Right? So some of the events are a little temporal. If you have a child with chorea, he may not be having any other features, because by the time it comes, everything else has disappeared. Right? So this is, now when you have a child with streptococcal sore throat, this is how it looks. So you know that we say two things. We say that don't give a lot of antibiotics, because if you give irrationally antibiotics, it causes resistance. And most of the URI is viral. And we say if you don't treat a child with streptococcal infection with antibiotics, you're going to cause rheumatic heart disease. So how do you differentiate? Right? A child comes to you with fever and comes to you with throat pain. At that point of time, if you are giving penicillin, so you are eradicating that infection, the chance that is called a kind of, you can say, secondary, you are preventing rheumatic heart disease, like primary prevention. How do you differentiate? So actually, if you have rheumatic heart disease, you will find that this is a type of, you will find pus points, infections, you will find, and this is never going to be there in viral. So you may have white membrane-like things in diphtheria or EBV or CMV, viral infections also. But it is not usually like pus. Similarly, if you have viral, it will also involve the eyes. So there will be running nose, there will be watering from the eyes, there will be myalgia. But in streptococcal infection, you will never find running nose, you will not find myalgia. It's high-grade fever and throat pain. Right? If you look at the cervical lymph node, they are more likely to be enlarged in streptococcal infection. So by proper examination, you can differentiate. Then you have certain tests also. So we have a monospot test, use streptococcal antigen test. You just take a throat swab and you do a streptococcal antigen test. So it's not available, it's available in some places only. That will also help you identify. Or throat culture can help you identify. But if you find that a child has got follicles and only involvement of the throat, no running nose, no watering, no myalgia, and lymph nodes, it's more likely to be streptococcal. In that case, what drug would you like to give? We prefer penicillins. Amoxicillin or penicillin. So that is a drug of choice. You give that, and that is probably you are preventing rheumatic fever or rheumatic heart disease. Now you have Jones criteria, right? So you have major manifestations, minor, and you have to have supporting evidence of antecedent infections. So how do you diagnose? A child comes to you for the first time. In that case, you have to have either 2 major or 1 major and 2 minor, right? So just remember, this is something we expect every child to know. This is some of the basic things we expect you to know to pass MBBS. If you don't know Jones criteria, then you don't pass MBBS. So this is something that is very, very important. Right? So what are the major criteria? So has anybody made some acronym for this? Kuch banaya? Some say SPECS or CPCES, something like that. You make it for the major criteria. So you have carditis. So carditis can be clinical. It can also be subclinical, which is diagnosed on echo. Right? So sometime back, so this is why modified Jones criteria, this is given in 2015. Before that, it was only carditis. Now you find that clinically you don't find any evidence of, you don't have a murmur, you don't have any evidence of distress, you don't have cardiomegaly. You do echo, you have a child who's coming to you with, say, fever, polyarthritis, you have some features. You do an echocardiographic finding and you find some evidence of valvulitis. So that is also accepted as a major criteria now. Right? So carditis is both clinical and subclinical, which is diagnosed on echo. Then polyarthritis. So we are coming to polyarthritis. Again, now we've got revised Jones criteria, which has divided everything into low prevalence countries and high prevalence countries. Right? So if you have a prevalence of rheumatic heart disease, which is more than 1 per 1,000 population, or incidence in the school-going children of more than 2 per 1 lakh. So that is a high prevalence country, right? So India is a high prevalence country. If you have a low prevalence country, that means the incidence is less than 2 per 1 lakh population school-going, and the incidence of rheumatic heart disease is less than 1 per 1,000. That's a low prevalence country. So in that, there's a slight difference. For a low incidence country, you have to have polyarthritis, and that is usually migratory. So which are the joints which are involved? So usually in rheumatic fever, it's not the small joints, it's not the TM joint, it's not the spine which is involved. It's always the large joints which are involved. So you'll find, classically they'll say, Doctor, ye dard ho raha tha, elbow or knee or ankle or wrist. So these are the joints which are classically involved. And it is migratory in the sense, so the child comes to you with 2 days history of fever and joint pains. We do not want to give aspirin. We want to just see whether it's migratory. Right? So what we do is we just give paracetamol for the first few days to see the pattern so that you can diagnose. So usually if you find in over next 2 to 3 days, it disappeared. The elbow is improving and now the joint pains has come over the elbow. So that sometimes you find the wrist is involved and now it's the elbow. That is additive. If the wrist, this elbow improves completely and it comes to the next joint, then that is called migratory. So it's classically migratory, but sometimes we find additive also. It's this joint and then it progresses to this. So why if we want to differentiate is because a child may be coming to you with JIA or septic arthritis and you want to differentiate these because the treatment is absolutely different, right? So in a high prevalence country, it's even monoarthritis or polyarthritis or polyarthralgia, just joint pains. That is also taken as a major criteria. And in low prevalence country, it has to be migratory polyarthritis. So in our country, even if you have a single joint or polyarthralgia or polyarthritis definitely, then it is a major criteria. Then erythema marginatum, I've got some pictures, I told you, it's seen over the trunk. They have these irregular margins which are raised like a wheel, right? But they are transient. They persist only for some days. So they're not going to stay for a very long time. And because most of the Indians are dark, you may not find it in all the children. Then subcutaneous nodules will be there and chorea. So chorea comes usually very late, by the end of 3 months. So by the time you have chorea, you may not be able to get all the other criteria, right? And how does chorea come to you? Suddenly the parents will say, "Doctor, bachcha jo hai bilkul pareshan rehta hai." So you find suddenly he's flinging, he's got emotional lability. The handwriting has deteriorated, right? And they have this, the child is picking up things, he's dropping. Suddenly the child has become very clumsy. Right? So they say, ajeeb si harkatein karta hai. And when you examine the child, you find that suddenly he's trying to pick up something. So the child has got, it's possessive. He's trying to hold the cup and then he suddenly overshoots. He's trying to bring the pencil and then suddenly it overshoots. Right? And then that disturbs the child. And suddenly you find there's emotional lability. The handwriting has deteriorated. And there are some signs. We are coming to that also. Then minor manifestation, again fever. So fever in a high prevalence country is more than, wherever there is high prevalence is 39, in a 38.5, in a low prevalence is 38. And again arthralgia. Even monoarthralgia will be taken as a symptom in a low prevalence country. Then lab features, you have elevated acute phase reactants. So what are acute phase reactants? ESR and CRP or acute phase reactants also. Other than that, you have TLC. What is TLC? Total leukocyte count. So usually you know that you have a range of 4 to 11. So the TLC is usually elevated. Then ESR. ESR again is usually in a low prevalence country more than 30, high prevalence more than 60. Have you been taught rheumatic fever in medicine? Pathology? इसमें आ गया था तुम्हारे इसमें have they divide मतलब that the new criteria had they come? Because they are there since I think 1.5 to 2 years. So CRP should be more than 3. CRP should be more than 3. ESR in high prevalence more than 60, low prevalence more than 30. So you have some differences. Fever ka cutoff alag hai. ESR is different, right? And prolonged PR interval. Now you know what is a prolonged PR in an adult? Anyone? When do you say that's a first degree heart block? So what is a normal PR? It's 0.2 seconds, 0.2 milliseconds. But when we talk of prolonged PR, in smaller children it's going to be less. So for a small child, it is more than 0.14, less than 5 years. 6 to 12 years is 0.16. Then beyond that only, adolescent age group, we take it to be more than 0.2. Then you have to have supporting evidence of antecedent infection, which can be in the form of positive throat culture or rapid antigen test, which is taken, somebody has taken it at the acute time, or elevated ASO titers. Anyone knows the cutoff for the titers? It's more than 250 TORS unit in adult and 333 TORS unit TU in children. So that is 333 TORS unit in children and 250 TORS unit in adults. So you have to have either 2 major or 1 major, 2 minor, right? And you have to have one of these at least. Then only you can say that the child fulfills the diagnosis of acute rheumatic fever. Now why that is important is because once you have diagnosed the child as rheumatic fever, you will put this child on secondary prophylaxis and you will give anti-inflammatory for 3 months, 12 weeks. So it's only when you have completed this criteria. So you have to know these criteria, right? So this is the low risk population. Low risk is less than 2 per 1 lakh, incidence of rheumatic fever less than 1 per 1,000, incidence of heart disease. Moderate and high risk is incidence of rheumatic fever is more than 2 per 1 lakh and prevalence of rheumatic heart disease is 1 per 1,000. So again, carditis is same, clinical or subclinical on echo. Again, I told you this is the difference. In arthritis, in low risk population, it's only migratory. Here you can have monoarthritis or polyarthritis or polyarthralgia. Chorea, erythema marginatum, the remaining 4 are absolutely same. It's only the arthritis in the major criteria, which is different in the low and the high income countries. Among the minor criteria, polyarthralgia, monoarthralgia. So this is difference. The cutoff of fever is different. The cutoff for CRP is different. ESR is different. PR and ECRP is same. The remaining are same. Right? So you have to have, if a child is coming to you for the first time, it's 2 major or 1 major and 2 minor. But if a child is diagnosed to have a rheumatic heart disease, and so you know now that subsequently if he develops a secondary infection, he's going to become very serious. So here what you do is, you take even 3 minor criteria to be positive rheumatic fever. So if a child is diagnosed, he's already on prophylaxis, and he comes to you, like the child says, "Aisa, hum to 1.5 saal se dawai le rahe the, we were taking antibiotics, and again since the past 3 days the child is having fever and this joint pain." So now you're not going to all the major criteria, even 3 minor, and you will again start anti-inflammatory immediately. You don't want a damaged heart to be damaged any further, right? And even in Korea, you may not find all the manifestations to be fulfilled. So what is the type of arthritis? I told you classically it's migratory. Migratory means, so if a child comes to you with fever and joint pains, so what will be your differentials? Your child comes to you with high-grade fever and joint pains of your knee joint. What would you think of? What is the first differential? One major joint is involved. Septic arthritis भी हो सकता है. It could be septic arthritis, or it could be the beginning of rheumatic fever also, or even it could be sometimes you have transitory or reactionary arthritis, right? It could be sometimes hemophilia presence like this. So you can have a lot of differentials, but what we are worried about is septic arthritis. Why? Because in septic arthritis, you have to give antibiotics very fast. We give IV antibiotics very rapidly because otherwise a lot of pus will collect, the vessels undergo thrombosis, and the cartilage of a child can get damaged, or the metaphyseal or epiphyseal plate gets damaged. We don't want that to happen, because if that happens, then child will have limb shortening or persistent joint pains in a weight-bearing joint. Is going to affect his quality of life. So again, what we do is we investigate. And we do not start an anti-inflammatory drug immediately. We just give the time 24 to 48 hours to see the pattern of fever. If it is migratory, you will find that over the next 24-48 hours, the fever, the joint of that knee joint will recover, and the ankle joint, the pain will come over the next ankle joint. So usually we just start with paracetamol and we investigate, right? So it's migratory, and it does not, if the small joints are involved, then it's more likely to be TIA, more likely to be rheumatoid arthritis. Okay, it's not, small joints are never involved in rheumatic fever. It's rheumatoid JIA, rheumatoid arthritis. Got it? So it's not going to involve the TM joint. It's not going to involve the spine. So these are not the joints which are involved. And do they have signs of inflammation? Yes, exquisitely tender. बच्चा बोलेगा डॉक्टर साहब कपड़ा भी नहीं रखने दे रहा उसके ऊपर. He will, if the child is a boy, he is not ready to wear a pant, because every time even the pant touches his limb, he cries. It's so painful. Absolutely सारे signs of inflammation, rubor, tumor, डोला, मतलब red, hot, inflamed, tender joint, right? But it is never deforming. And usually when we start aspirin, within 48, 72 hours, everything just vanishes. Child is as good as new, he's walking and running, right? So that is again the therapeutic test that we do. It's not going to affect. If you have a child with JIA, you will find nothing happens with 3 or 4 doses of aspirin. There's a slight relief of pain, but it will keep on coming. But if it is rheumatic fever, it will come completely okay in 72 hours. The child will have no symptoms at all, right? And again, the good thing about this is it is not deforming. It is going to recover. The child will have no involvement of after you have given the anti-inflammatory drug, the joint is going to be absolutely normal. There is no deformity, no sequelae. It's the carditis we actually worried about. Nowadays, subclinical carditis is also taken. That means the child has no palpitations, no features of CCF. You just do an echo and you find evidence of joint and the heart involvement. So that is also taken as evidence of carditis. Carditis is pancarditis. If you remember, you find that Aschoff nodules are present even in the pericardium, myocardium, endocardium. It's all the 3 joints which are all the 3 layers. So if it's pericardial involvement, how does it present? Parents will complain of, the child will complain of chest pain. If you examine, you will find a rub, right? And is there something happens to ST and T waves? So ST and T waves show concavity whenever there's fluid. But the fluid is usually never so massive. Sometimes if you've seen pericardial effusion, because of either tuberculosis or other causes, they have tamponade, massive effusion. But in rheumatic fever again, the effusion is not very massive. Then again, myocardial involvement may be there, but it's the endocardial involvement we are worried about, and the most commonly affected valve is mitral. By and large, if you go to medicine, you will find mitral stenosis. But in pediatric, it's the mitral regurgitant lesion, which is mostly what we find, and even sometimes aortic involvement. And sometimes when the myocardium is involved, the entire heart is dilated, then you may have a functional TR also. But by and large, without involvement, 90 to 95% is the mitral valve involvement. So what is the classical murmur seen in rheumatic fever, anyone? Have you heard of Carey-Coombs murmur? What is the murmur that is heard in MR? Pansystolic. So Carey-Coombs murmur is a delayed diastolic murmur. So that is the classical murmur that you hear in rheumatic heart disease. So actually, you know that MR will give you a pansystolic murmur. So why is the diastolic murmur seen? That is again because you find that the valve doesn't open nicely, doesn't close, and you find a flow murmur. So that is a delayed diastolic murmur that is seen in rheumatic fever, that is classically described in rheumatic fever, and that is known as a Carey-Coombs murmur. And MR is the most common lesion that is seen, right? And after that, aortic. So it's usually the left side. Right side is less involved, pulmonary valve, never. Chorea is a movement disorder, emotional lability, poor school performance, and it comes very, very late. By the time you have chorea, you may not have anything else. Erythema marginatum is rare. It's non-pruritic rash seen on the trunk and extremities. It spares the face. And subcutaneous nodules, they are small nodules. I told you, from pinhead to size of almonds, which you are very careful, you may find. Right? So over the shin of the tibia, occiput, sometimes along the tendons of joints, you may find. And they have a good correlation with cardiac involvement. So what we find is children who have subcutaneous nodules, a lot of them will be having cardiac involvement. Right? So this is the mitral valvular involvement. I've already told you this. So again, where will you not expect all the Jones criteria to be fulfilled? That is, one of them is indolent carditis. That means you have a child who has come to you with cardiac features for a long time. So he's got something on echo, he's breathless, and you do an X-ray, you find a cardiomegaly. So sometimes indolent carditis. So it's not classic, the child may not present you with fever and arthritis. Similarly, when you have chorea, because it comes so late, the acute phase inflammation, the sore throat, everything else vanishes. So again, in chorea, you may not have, if you have removed all the other causes of chorea, that is Huntington's chorea and Wilson's disease, then we treat a child as rheumatic heart disease because you may not fulfill all the criteria. Similarly, if a child is a diagnosed case of rheumatic fever, then when he comes to you with a recurrence, because you know his heart is already damaged. So if the child is on penicillin prophylaxis since 3 years, he comes to you with fever, joint pains, breathlessness. Now you're not trying to fulfill every criteria, even 3 minor, and you start the child on anti-inflammatory because you want to suppress the inflammation to prevent further heart damage. So these are the echocardiographic findings, certain Doppler criteria, certain morphological criteria, which are now taken, even if the child has no features, If you find that the valve annulus is dilated, or the chordae tendineae is elongated or ruptured, or there is valve prolapse, right, or there is a jet velocity of more than 2 centimeters in true projection, right, either mostly in the mitral and aortic valve, then you will say that, right, so if you find any of these findings, you find that the valves are thickened, the mobility is reduced, you have a nodule at the end of the tip. So any echocardiographic finding which suggests valvular involvement in the absence of clinical features is known as subclinical carditis. And that is also taken as a major criteria, right? So this is how usually we find that a child comes to you with acute carditis. So what can you find here? There is, you know what is CT ratio? This is, you find there is cardiomegaly, and this is the pulmonary increased pressure that is going. So you have a kind of, this increased pulmonary blood flow is causing this kind of pulmonary plethora. So what is CT ratio? CT ratio means you draw a straight line like this, right? Then you take the maximum distance from here and the maximum distance here. You have added these two, this is the cardiac ratio. Then you take the thoracic ratio that is in the left lobe of the diaphragm. So you draw a straight line like this and you calculate the thoracic ratio. So you C by T ratio, if it is more than 0.5, then that is called cardiomegaly. So here you are finding cardiomegaly. And why is it CCF? Because you find that the entire lungs also, they are showing a lot of plethora. That means a kind of pulmonary edema-like manifestation. So it is cardiomegaly, and this could be acute rheumatic fever. Not be able to say it is acute rheumatic fever, but it looks like it. So these are erythema marginatum. See, irregular margin raised, right? Slightly, you can find that the centers are slightly pale. Not very easily seen. These are the subcutaneous nodules, right? So see, erythema marginatum in the fair-skinned individuals, they are very common. We haven't seen a lot of erythema marginatum. We've seen some subcutaneous nodules, but not so common again. So this is, they are testing the child for rheumatic chorea. There are some signs for rheumatic chorea. So in rheumatic chorea, now you have a child, parents say, "Doctor, बच्चा जो है बिल्कुल हाथ अजीब से कर रहा है, कुछ भी पकड़ने में हाथ गिरा रहा है, अजीब सा behavior होता है, कभी ज़्यादा रोने लगता है, कभी ज़्यादा." So you find a child who was improving, suddenly you find there's deterioration in academic performance, he's crying a lot, he's become clumsy, that is what they say. हर चीज गिरा देता है, खाना तक मुंह पे नहीं खा पा रहा है. So again, you want to know whether it's dystonia or chorea. So there are certain signs. One of them is pronator drift. So what we tell them to is, we tell them to raise their hands above their head. And you find, suddenly you will find that they will show, this is like kind of pronation. So this is called pronator drift. The milkmaid grip, you tell them to hold your hands tight. And you will find, जैसे आपने देखा है, when they milk a cow, what do? Alternately contracting and relaxing, right? So you'll find that the child holds your hand, he's contracting and relaxing, He's not able to pull it like this. So this is called milkmaid grip, right? So tell the child to hold one finger and you will find there's alternate contraction and relaxation of the hand. Then spooning. When you tell the child to put his hand outstretched, you will find the hand becomes like this. Okay, this is called spooning. Then if you tell them to tell them to protrude their tongue, you find there is jack-in-the-box phenomenon. That means the child takes out his hand and then suddenly he'll pull it back. You've seen jack-in-the-box? Pull out the clown, it suddenly comes out. So the child takes out his tongue and then he pulls it in. Right? So that is called jack-in-the-box. So you have pronator sign, means when you tell them to put their hands like this, there will be pronation. You find their medial deviation like this. This is called spooning. You find milkmaid grip and you will find jack-in-the-box phenomena of the tongue. So again, usually because by this time ESR, CRP, ASO titers may come back to normal. You may not find all these signs. You may not find clinical carditis. Some of them will have clinical carditis. Polyarthritis, it will improve by this time because even if they have taken 3 or 4 days aspirin or indomethacin, any anti-inflammatory, joint pains has gone. So again, you have to rule out some other causes. You may have to do an MRI brain to rule out Huntington's chorea and other causes of chorea. And once that is ruled out, you start the children on certain drugs to control chorea and secondary prophylaxis. So what do you ask them? You ask them, was there history of rheumatic? What will you ask them? Will the child have streptococcal infection at the time of joint pain, arthritis? No, because it is not an infection. It is an immunological phenomena. So there will be history 2 to 3 weeks back. Right? Then again you ask them, is there related to joint pains? Joint pain in the joints, right? Chest pain, swallowing difficulty, trembling, flinging of the hands. And for CCF, you'll ask them history of heartbeat, palpitations, swelling, fainting spells. You're examining their throat, but do you expect to find a lot of findings? Throat culture, throat swab, we do it routinely. So, but mostly you will not find. And we still give a dose of penicillin, benzathine penicillin to every child. Why? Knowing fully well that it is an immunological phenomena, because we don't want to eradicate that rheumatogenic strain. Okay, we don't want, in case the child is still a carrier of that, we don't want him to spread the rheumatic strain to other children. We don't know who's more genetically susceptible, so just to eradicate that strain, once you have diagnosed the child as rheumatic fever, we still give them a course of 10 days penicillin or a single dose of benzathine penicillin. Then you examine for chorea, you look for joint pains, look for erythema marginatum, you look for nodules, you look for fever. And you auscultate, you're looking for what are you looking for basically? What is the murmur that you expect in MR? Pansystolic. Oral, Carey-Coombs murmur. Or if it's AR, where will you find the murmur? Which is the aortic space? First and second space kuch hoti hai aortic. Which side is the pulmonary wall? Which side is the aortic? So this side, it is the right side is the aortic, left side actually here, which side, and third space is the second aortic space. So you may have an aortic murmur usually goes to the neck or in the interscapular region. You may have to examine the child, and it's usually mitral valve. I told you 95% it is mitral valve. So mitral valve is usually the murmur is heard at the apex or just medial to the apex. Usually it's a pansystolic murmur or a delayed diastolic murmur, which is a classical finding in. And again, if they have carditis, S1 is soft, and if there is a gallop rhythm, what is gallop? So it's a protodiastolic murmur you find. You find that the additional sound. Normally it's tuck, tuck, tuck. You've heard, it's lub, dub, lub, dub. But here what you find is, you find there are some additional sounds. So that is actually gallop rhythm. So many children will have no classical murmur, but they will have a gallop rhythm. Right? So how do you manage? So you have diagnosed the child as rheumatic. You know that there was a streptococcal infection, but now there is some inflammation. This inflammation is damaging the heart. I'm worried about the heart, and I want some secondary prophylaxis. So what are you going to do? So it's basically cardiac involvement. So this is one condition you want them to have strict bed rest, because you don't want to increase any workload on the heart. Right? So you give them rest, and what else will you do? Right? You manage the streptococcal sore throat. So I told you, even though we find that the streptococcal sore throat was there in the past, but we want to eradicate that strain, so what are we doing? We still give us either penicillin for 10 days or a single dose of benzathine penicillin. So what are the type of penicillin that you know of? Oral penicillin kya hoti? What is oral penicillin? Phenoxymethyl penicillin. So we give that penicillin. For adults is 500 milligram BD. For children is 250 milligram BD. Injectable penicillin. What are the types of injectable penicillins you have? You have benzyl penicillin, which is given 6 hourly. Then you have procaine penicillin, which is given every 24 hours. Then you have benzathine penicillin. Right? So which penicillin are we giving? We are giving benzathine penicillin, which is being given, which is used every 2 to 3 weeks. 3 weeks at least. Right? So that is what we are giving. We prefer out here. And it is always given after sensitivity. So this is one drug which can cause anaphylaxis. Any drug can cause anaphylaxis, but penicillins are especially known to cause. So whenever you are giving an order, it is always AST, that means after sensitivity test. Then we give anti-inflammatory drugs. So which anti-inflammatory drug do we give? Either we give steroids or we give aspirin. So what drug do we prefer? If there is severe cardiac involvement, then we will prefer steroids. We know that steroids are toxic. They have a lot of side effects. And aspirin in children, it is a little toxic in the sense because it can cause tinnitus, it can cause Gray syndrome. But again, we want a proper anti-inflammatory, and it is a very effective drug. So if there is no cardiac involvement or mild cardiac involvement, then we will start aspirin. And we give it in tapering dose over 12 weeks. That means 3 months. Why over 12 months? Because there is ample evidence to show that this inflammation persists for 3 months. If you're starting with steroid, we start with steroids, we taper it over 2 to 3 months, and when you are tapering, you start aspirin and you complete the course for 12 months. If you're starting with aspirin, then you continue that for low dose. If there is only joint involvement, the cardiac involvement is not there, then you will give only aspirin. Right? Then you manage chorea. For chorea, because the symptoms, they will disappear completely in 2 to 6 weeks. It's not going to cause any debility lifelong. So we control, for that duration, it's very problematic. For instance, if a child is 12 or 13 years old, the child is not able to write in class, he's not able to sit, he's not able to take a glass of water, the child becomes very anxious. You tell him to lift a glass of water and he panics because he knows, I was able to do this some time back, now I know as soon as I take it's going to come here and then I may be just dropping it. Child tends to become very anxious, so you may have to control these symptoms either with haloperidol or promethazine or sometimes even with phenobarbital. Then if they have atrial fibrillation, then we give digoxin and other drugs and we give prophylaxis. So prophylaxis, we are coming to that, that's very important because prophylaxis prevents further recurrence also and it does not allow the disease to become severe. So this is a treatment algorithm. So you give bed rest, you monitor the child, for especially in children with carditis. And carditis also, subclinical, we are not very worried. They can be managed at home basis. It's the child who comes with you with a huge cardiomegaly and severe breathlessness. So they have a gallop rhythm, right? And they are breathless. They have NYHA grade 4 dyspnea. These are the children. If you give them a little bit of fluid also fast, they will land in fluid overload. So they are very difficult to manage. So we give them a single dose of benzathine penicillin on 10-day course of penicillin. If they are allergic to penicillin, which are the drugs which can be given? Erythromycin or azithro or even clindamycin. Right? If there is only arthritis, then we start with aspirin. It's 50 to 70 milligram for 5 days and then we taper it off, right, gradually over 6 to 12 weeks. Carditis without cardiomegaly. So that is only diagnosed on echo, subclinically. Again aspirin. Carditis with cardiomegaly or CHF, then we will start with steroid. Right? Otherwise it's aspirin. So when we start with steroid, which steroid are we giving? We are giving prednisolone. And which route are we preferring? We are preferring oral. So we start with oral prednisolone 2 milligram per kg per day. After 2 weeks, we begin to taper off the steroid. And what will we monitor? We can monitor inflammation. Which marker can we monitor for inflammation? CRP and ESR. You will find that CRP and ESR will start to decrease. So once it is in the lower range, then you start with aspirin. And you start with aspirin 70 milligram per kg and you begin to taper off the steroid. And you monitor the CRP. Once CRP is back to a little bit to a normal, then you can stop the steroid and continue the child with aspirin for 12 weeks. Right? Along with that, what are the drugs that we give for CHF? We give diuretics. Right? And we give ACE inhibitors and strict bed rest, restriction of fluid. Then if you have chorea, usually by that time you will find that inflammation has disappeared. ESR and CRP may be absolutely normal. So again, if the inflammation is normal, the heart is not involved. Then anti-inflammatory may not be needed because inflammation persists for 12 weeks. And the child has come to you after 4 to 5 months maybe. So here what we do is we control the symptoms with phenobarbital, haloperidol, promazine, and you look for cardiac involvement. If you find that ESR and CRP is raised, then you may give aspirin, otherwise it's not indicated. And you start the child on secondary prophylaxis. Right? So this is actually what is happening. It's involving so many parts of the body. It's involving the heart, right, the joints. It's involving the brain in the form of chorea. So again, what we are doing is, so there are different forms of prevention. You have primordial prevention. What is primordial prevention? Primordial, primary, secondary. Primordial means you don't let anything happen. So that means before things have occurred. That is probably vaccination. That is not exactly very much possible to sensitize people. That's not actually possible. Why? Because again, every primary prevention is also not absolutely, because a lot of subclinical infections also give rise to rheumatic fever. What we can do is every time you have a child with sore throat, you try to identify whether it's streptococcal and you treat it appropriately with penicillins. So that is one thing that you can do. That is primary prevention. Then what we are doing is, again, dental hygiene. Why are we talking about dental hygiene in a child with rheumatic fever? Because we know the commonest cause of infective endocarditis is dental. So any child with a cardiac problem must be told about dental hygiene because this is the infection which goes straight to the heart. And infective endocarditis occurs more, it can occur in the native valve also, it can occur in our heart also. But it is more likely to infect a damaged valve. And infective endocarditis is very, very, very serious. You have to give antibiotics for 6 to 12 weeks. Imagine getting injections for 3 months. It's so problematic. And apart from that, that vegetation further damages and kills the heart wall. So it's so problematic to admit a child and give antibiotics. If you have to give antibiotics even for 5 days, you'll find it problematic. For 2 to 3 months, that is a very big problem. So again, dental hygiene should be told to any child who has rheumatic heart disease. And secondary prophylaxis means now any child who has cardiac involvement, you are going to give them penicillins so that there is no recurrence and no further damage of this damaged heart. So which drug do we give? We prefer benzathine penicillin. So what is the dose that we give? For more than 27. Why have we taken this cutoff of 27 kg? Because that roughly corresponds to 1 meter square body surface area. So if a child is more than 27 kg, it's 1.2 million units or 12 lakh. And that is given every 21 days. Less than 27 kg, it's 0.6 million units. How expensive is it? It's very cheap. It's only 12 or 13 rupees. But it's not easily available. And many people don't want to give it because anaphylaxis occurs after giving this. Sometimes, once in a while. So again, a lot of people are not ready to give these drugs. So that is given every 15 days. Then again, sometimes this is very painful. The powder is so thick, it tends to clog and it's so painful. Usually we call the children on Friday or Saturday so that by the time they go to school on Monday, they are able to walk. So it's a painful injection. So sometimes you find that the child will start howling and crying. He's not ready to come to the hospital. And but this is the most effective thing. If the child can take penicillin prophylaxis, because you have to give it for a very long duration. If there is cardiac involvement, then we give it to at least 40 years if it's in a damaged heart. If there is carditis but the heart is not permanently damaged, then again for at least 21 days or 10 years. And if there is no cardiac involvement, then also we give it till at least 18 years or 5 years, whichever is more. So the duration is so long that if you have to give them oral drugs, the compliance tends to be very poor. And you will find that the child will keep on coming to your already damaged heart. Again, if the child has rheumatic heart disease, he will land in CCF. It may not be always able to salvage that child also. So, but sometimes you find that the child is just not ready to take injections or it's not available or they are very far. In that case, you can give oral penicillin. That is called Capen phenoxymethylpenicillin or penicillin B. In children is 250 milligram twice daily and in older children is 250 milligram twice daily. The prophylactic dose is BD and for treatment it's QID. Okay, so the treatment and therapy range, the dose is different. Azithromycin and cephalexin are not given for prophylaxis. They can be given for treatment of streptococcal infection. They are not recommended for prophylaxis. And erythromycin can be given if a child is allergic to penicillin, then erythromycin can be given for twice a day. 250, again the dose is 250 of one smaller children less than 27 kg, 125 BD, more than 27 kg, 250 BD. This can be given. How long to give? Right, so again, rheumatic fever without carditis, 5 years or till 21 years, with carditis but without residual heart disease. That means in the beginning there was cardiac involvement. You got an echo done after 3 to 4 months and you find that the valve has recovered. In that case, it's 10 years or 21, whichever is longer. If you find at the end of 3 to 4 months, the child has MR or AR, that means a residual heart disease is there. Then they have to be monitored. If the child, you find the quality of life is good, but some of these children sometimes need valve replacement also. In that case, it's 10 years or until 40 years, whichever is longer. If they need valve replacement, then it is lifelong. So this is just in brief. You find the valvulitis, you find a pericardial rub, you find myocarditis, edema marginatum. So something you can form a picture in your brains so that you remember all the features. I just got this. I thought probably you can, if you can remember some things, you found a picture that all these parts of the body are involved. It's for you to remember. So now I'm just going to randomly ask you. This is a 13-year-old boy. He came with complaints of breathlessness for 2 days. 10 days back, there was sore throat with pain in the right ankle, followed by left knee, right knee over 3 days, not associated with swelling. It decreased with treatment from a registered practitioner. Now the child is breathless. He's 4th birth order, overcrowding is present. He's thin-built, he's sick. He's 13 years old, his heart rate is 120 and respiratory rate 40-40. Pedal edema is present, JVP is raised, and there is a hyperdynamic apex with a S3 gallop and a pericardial rub. Liver span is 11 centimeters. So, can anyone tell me which part of the Jones criteria is the child fitting? What is your first diagnosis? Anyone? What does the child have? See, I've just taught you the whole thing और बिल्कुल classical सा case दिया है. अभी भी कुछ नहीं बोल रहे हो. It's acute rheumatic fever. Why? Anyone? Which criteria is he fulfilling? Anyone? Can anyone answer? Otherwise, I'll just take random roll number. 50. Roll number 50. 40. You can sit and answer. Now, if you remember the major criteria, out of these, what do you think the child has? See, one thing he has is, out of the past history, there is history of sore throat. So that is history of streptococcal infection. The third line that one of them has to be fulfilled. There has to be history of or some evidence of streptococcal infection. Then the child has got ankle, knee and right knee, but it is pain, not swelling. So what is it? If there was pain and swelling, it would be arthritis. There is only pain, so it is arthralgia. But we are a high prevalence country, moderate or high risk, so it will be a major criteria. Okay, so this is polyarthralgia. This is a major criteria. Then the child has got, what else have you got? He's sick looking. Heart rate is 120. Is that tachycardia? For a 13-year-old? Definitely. Respiratory rate is 40. Is it tachypnea? Yes. The JVP is raised. What does it tell you? S3 gallop. It tells you that the child has got CCF. That means it's clinical carditis. Okay, so if the child has clinical carditis becomes a major criteria. Then if the child has got fever again, then you have, how many criteria do you need? You've got 2 major criteria. So does it fulfill your Duckett-Jones criteria? Yes. Which test would you like to do? Now, you would like to look for signs of inflammation. So you look for TLC, you look for ESR. Fever कितना होना चाहिए इसमें? 38. ESR should be more than, we are a moderate to high risk country. More than 30. CRP should be more than 3. And PR interval may be prolonged. The child is 13 years old, so it should be roughly more than 0.16. If these criteria fulfill, what test would you like to do? Echocardiography करना चाहोगे? ASO titers, ठीक है, X-ray for cardiomegaly. So that is what we'd like to do.